Welcome back to Pharma Pro Mastery Hub, where pharmacy profession meets clarity, confidence, and mastery. So today we'll be exploring a skin infection that is more common and more contagious than most people think. And that skin infection is impetigo. So we'll be understanding impetigo. Impetigo is a superficial bacterial skin infection. When we say something is superficial, what we are trying to say is that it affects only the outermost layer of the skin. And bacteria, meaning it is of bacterial origin, it is caused by bacteria invading the skin. So there are two organisms that primarily cause impetigo. We have Staphylococcus aureus and Streptococcus pyogenes. We have two clinical forms of impetigo, the primary impetigo and secondary impetigo. We'll be looking at each of them. So for primary impetigo is a type of impetigo that develops on previously intact and healthy skin. And what this means is that there was no pre-existing skin condition or trauma before the infection began. Now it is one of the most common skin infection in children, particularly in hot and humid environments. So let's look at the causative organism for primary impetigo. Primary impetigo is caused by Staphylococcus aureus, and Staphylococcus aureus is commonly found on the skin and in the nasal passage. It can produce toxins that can lead to bullous impetigo. Under primary impetigo, we have bullous impetigo and non-bullous impetigo. The next causative organism is Streptococcus pyogenes and is often implicated in non-bullous impetigo. It also spread very rapidly, especially in children, and in most cases, both organisms might be present together as co-infection. So, who are at risk? It's most common in children aged 2 to 5 years, and it's occurs especially in hot or humid climates, and it is common in environment with close contacts like schools, daycare centers. It easily spreads because of this close contact. So let's look at the pathophysiology of primary impetigo. When there's minor skin trauma from insect bites, scratches, or friction, it causes a small breach in the epidermis, which will now lead to bacteria colonizing the sites and causing localized infection, which is limited to stratum corneum. So let's look at the clinical presentation of primary impetigo. So we have non-bullous impetigo, which is also known as impetigo contagium. Now, this impetigo type of impetigo accounts for about 70% of all cases. It starts as a small red papules, then it develops into a vesicle or pustules, and then it ruptures and then form golden yellow or honey-colored crust. And it's most common around the nose, the mouth, and the lips. Sometimes it is mildly itchy, it is not painful, and it is caused by streptococcus. Then the next type of primary impetigo is bullous impetigo, and this is caused by toxin forming Staphylococcus aureus. It presents with larger fragile blisters that are filled with clear or yellow fluid. Now, after its rupture, they leave behind red or moist base. It's more common in infants and neonates around the trunk, buttocks, and diaper area. So the next type of clinical form of impetigo we'll be looking at is secondary impetigo. Now, it's a type of impetigo that occur on top of pre-existing skin conditions or injury. Now, unlike primary impetigo, the skin is already compromised before bacterial invasion. Causative organisms for secondary impetigo include Staphylococcus aureus, Streptococcus pyogenes, methicillin-resistant Staphylococcus aureus. This might be involved especially in recurrent or hospital-acquired cases. Now, when we talk about methicillin resistance, we are talking about the resistant strain of Staphylococcus aureus, and it doesn't respond to the beta-lactam antibiotics. So common underlying skin conditions that can lead to secondary impetigo include atopic dermatitis, that's eczema, scabies, insect bite or chickenpox lesions, burns or wound, contact dermatitis, herpes simplex, im- impetiginized lesions. Now, these conditions create entry for bacteria, which will lead to secondary infection. So why does secondary impetigo matters? Because it is more complicated than primary impetigo, as it requires dual management. You are treating the impetigo and then you are addressing the underlying skin condition. Clinical features of secondary impetigo: there's oozing, crusted sores on already inflamed or itchy areas. You have your honey-colored cross, which may still form, but they are often irregular or widespread, and the skin may be more inflamed or more painful safe than in primary impetigo. And it has the tendency of spreading more rapidly because the skin is already compromised. So to diagnose impetigo is usually based on the characteristic lesions, but in some cases do a swab and culture test to check for especially in recurrent infection. You do a gram stain to also check to know if it is what positive coca in chains or clusters. Treatment depends on the extent, the location, and the severity of the infection. Topical antibiotics are usually the first line, like mupirocin and then fusidic acid. Retapamolin is also a topical antibiotics, and it is from the pleuromucilin class. You could also use that to treat impetigo. Oral antibiotics for widespread impetigo, bolus, or resistant cases use flucloxacillin, cephalexin, erythromycin or clarithromycin. If there's penicillin allergy, you could also use amoxicillin clavulanic acid. So oral antibiotics for treatment of impetigo, you could use flucloxacillin, you could use cephalexin or erythromycin or clarithromycin or amoxicillin clavulanic acid. Then in methicillin resistant Staphylococcus aureus endemic areas, you could use doxycycline or clindamycin or cotrimazole. It is important to know that referral is not weakness. Referral doesn't mean you don't know your job. Referral means that you care about the patient. So you refer if there's no improvement in 3 to 5 days, if it is a recurrent impetigo, if there's sign of cellulitis, lymphangitis, or systemic symptoms, refer the patient so that a lot of things will be look into, and then the patient can get well. Ensure as a pharmacist you always follow up after referral. It is very important. So preventing impetigo is possible with good hygiene and awareness. Regular hand washing is important. Avoid sharing personal items. Clean minor cuts and abrasions promptly. Treat underlying skin conditions like eczema because it will predispose one to other infections. Educate parents and caregivers about early signs and isolation. By isolating, you have broken the chains of spread of this infection. And then counseling points: gently clean lesions before applying topical medication. Don't scratch, keep your nails short. Avoid sharing towels, bed sheets, razor, or clothes. Cover lesions to reduce spread. Keep infected children at home until 24 hours after starting antibiotics. Encourage adherence to full antibiotics course even if the rash improves. So ensure you tell your patient this as the person is coming to get drug. Ensure you tell them so that the treatment will be effective. If you found this video helpful, don't forget to like, share, and subscribe for more. Thank you.